Hey, what's up, guys? Long time no see. I've been a little bit missing in action. I know it's lunch hour, so I don't really expect a lot of you guys to be showing up live right now, but I'm hoping you can catch it later. I'm just going to find myself real quick on this other account, and I want to actually go live on two streams here. Hey, what's up? And what I'm going to do is go over something. Give me 1 second. I want to actually. Give me 1 second. Let me just bring this down. So what I'm going to be doing is going over some of the things that I come across when I'm restoring overdentures. So I want to share a couple of pictures with you, a couple of slides, and I'm actually going to show you on this split screen real quick. Let me just bring it up here. Hey, what's up? What's up, guys? What is up? How have you guys been? Oh, nope. Give me a second. All right, let me see. What's going on with this one? There we go. All right. What's up, guys? You guys catching me on this split screen here? You guys see what's going on? Let me just adjust this thing. There we go. Cool. So I'm going to be talking about avoiding failure with overdentures. I want to make sure you guys can still see me. I'm just going to be chatting with you for just a couple minutes, and then I'll get into it. Just because I want to allow people to join in, and I'm just kind of getting set up here. You guys haven't seen me for a little bit, just because I've had a little bit of downtime. Well, you guys all know already that I've been traveling with Olivia. She's got some consultations coming up. We went to LA to get her situated with the specialist. We're actually, there's no clear way to treat her condition, so we're actually kind of taking the initiative, finding the very best people in all the different aspects. So the best surgeon, the best interventional radiologist, the best everything. Oh no, is it still echoey? Hey, all right, let me know if it's echoey. Is it still echoing right now? Let me know. All right, so give me a thumbs up if it's not echoing. Oh, man. Damn it. Okay, how about now? Is now a little bit better if I just speak? It's still echoing right now? Damn it. That's why I tried this out the other day. Let me see. All right, so, darn it. So all right, so it's audible. Let's see. Well, it's all good. I'm going to go ahead and just share this stuff anyway, and I'll figure it out as I go along. This is my first time doing a little split screen here. Anyway, so I'm going to go over with you. It's not like a big presentation or anything. It's 5 minutes, just a couple of things that I've seen with overdentures that really are a pain in the ass. And I want to get your feedback. Ask me questions if you have any questions about it. And so let's go ahead and look at some of them together. Oh, let's go. All right. So this first one right here, sounding like amphitheater. Damn it. You know what? It's all good. Let's just do it, and then I'm going to rewatch it later and try to make it better. I could put some headphones on. Thinking about doing that. If I go inside, Olivia's going to ambush me. All right, let me just go over a couple things, and you let me know if the sound is too distracting, then I'll just retry. I'll close up this live session, restart a little bit later. But let's look at these first couple complications first. So this is a mandibular overdenture, obviously, and we have 2 implants placed. So does anybody know what complications come from this? Obviously, it says Rocky right there. But has anybody seen that? So when we got the 2 implants placed right there, right, and you see this denture is so skinny that there's no flanges on it. It doesn't extend all the way to the tissues. It doesn't have the proper support from the acrylic. that it actually rocks like crazy. So I'm going to show you right now. So that's the 2 implants right there placed. And so I'm going to show you how it rocked in the mouth. Are you guys seeing that? Yeah, so that's, I'm going to replay that just in case you missed it. See? So I see that whenever the implants are placed kind of like at the canine sites instead of a little bit anterior to the canine sites. And also if the acrylic is not well adapted. Hey dude, okay, can you guys hear me a little bit better, or is it pretty much, give me a thumbs up for this is cool, thumbs down for your audio sucks, and make it better. I'm going to wait for your responses, okay? But anyway, I see that the denture kind of like rocks, it rocks back and forth. And so what I did for this particular patient, I basically took out both of the housings. I just took them out a little high speed, popped them off, did a complete reline on the entire denture, and then I reattached those housings. And so, damn it, 2 thumbs up and 1 thumbs down. You know, it's all good. I'm just gonna keep going. Thanks, guys. I appreciate you working with me through this. It's all good. So anyway, after I did my reline and I re-picked those up, it was fine. But those can really be a big pain in the ass to deal with because over time it's going to continue to rock more and more, I think. So those are tough. What I recommend to this patient is maybe add 1 more implant. All right, so if you want, you can screenshot this. I'm not really going to go over specifically like in-depth stuff. Like I'm not going to read this to you because I'm just going to talk about it instead. You guys don't want me to read things to you. But it's pretty much what I'm talking about, right? All right, so how many of you guys have had this happen to you? This was like, oh man, I've been at like risk of this happening like 3-4 times, right? It's always worse when you go ahead and you're trying to pick up your denture, you're trying to pick up your metal housings, and then all of a sudden it doesn't pop out. Patient freaks out. Maybe peri-implant bone resorption. Yes, yeah, that's true. Like for example, if you're not delivering, I mean, if you're not waiting until the bone has resorbed, then and you make your final prosthesis, right? It's not going to fit well. Yeah, so I'm just going to touch back on what Dr. Modi said just real quick. So yeah, if you're delivering your overdentures soon after your extractions, like your final overdentures, guess what's going to happen like 6 months to a year later? 6 months to a year later, it's going to be rocking because the intaglio, you know, I don't even know if I'm saying that properly. You guys say there's no G in it or something, whatever. But yeah, it's going to be rocking because the tissue surface is going to change. The tissue is still changing. So what I like to do is I deliver a temporary right away, right? So 3 months later, I'll attach a temporary, and then I'll make a definitive a year later. So that's how I handle those overdentures, right? So I'll deliver a temporary one, then a year later I'm delivering a final one. All right, that works a lot better. It's a lot better than having something that's rocking on you, right? All right, so now let's see right here. So anyway, how many of you guys have had this happen? Anybody? Yeah. So I have a pretty cool trick to removing this. I've suggested it to a couple people that have asked me, and it's gotten them out of, and it's gotten myself out of some pretty crappy situations. So first of all, if you're not blocking out, just like I'm sorry, what's your name? Guara? I'm sorry, I don't want to mispronounce your name. So just like you said, if you're not properly blocking out the locators, you're going to lock in your denture, right? So the locators come with little blockouts, right? The little rings, they call them little lifesavers. So you put them around your locator, and then you do the pickup. If you don't have one of those, what you can use is some light body. You just put a little bit of light body around the locator, and that could act as a blockout. If you don't have that, well, I don't know. You should have light body. So, all right, what if you didn't do that? You forgot or whatever, and it's already locked in. Man, that's a big pain in the ass. So I'm going to show you, this is like worst case scenario. Worst case scenario is you cut your denture, And it's a big pain. I mean, the patient's all freaked out. You got acrylic dust everywhere, acrylic smoke going into the patient's mouth. So I'm going to show you. I'm going to show you what I do or what I've done to remove these things. I've probably used this trick like 2 or 3 times. What I actually do for mandibular dentures, I'll actually use a floss threader, and in the back over here, and in the back and the front right here, I'll pass floss threaders. I'll pass a long piece of floss, 2 pieces of floss here, 2 pieces of floss here, and 2 pieces of floss here. Okay, so I basically loop them around, tie them up top, and now you have 2 things to hold on inside, 1 thing to hold on in the front. And I'm going to go ahead and show you. This might not be the best quality, but check this out. This is how it pops out. 1, 2, 3, pull. You guys seeing how that pops out? So this is actually on my feed. Oh. Ooh. No. You guys ever get this? Temperature on your iPhone needs to cool down before you can use it. Damn it. I'm not sure what to do if I don't have my little secondary device here. Why don't I do this? I'm just going to switch this right here. Let me see. And we'll just do it like this for a little bit. All right, so this is how I pop it out. So I put the floss on either side, and then boom, pops right out. So that's saved me, and that's saved a couple of my friends a couple times. If you want, look for it on my feed. But that's like the best way. For the top, what I like to do is for the top, for the maxilla, what I like to do is just maybe get like a popsicle stick, like a tongue depressor, and put it on the just get a tongue depressor, put it on the flanges, and pop down on either side, and have the patient pop down too. But you can see in this video I just showed you, it's a team effort, right? So it's going to be like you, the patient, and your assistant counting to 3, being 1, 2, 3, and everybody pulls as hard as they can. That's the only way to do it. If you try to pull and the patient tries to pull, everybody freaks out and then nothing gets done. So let's go ahead and go over this next one. You guys see my little beach towel, a little towel. We go to the pool a lot. Here's another complication right here. It's going to be tori. So if you're not removing these tori before you deliver these dentures, you got to, and it's causing a problem, like if the patient is in pain, what you got to do is flap, burr that down, and then do a soft reline. I like to do a soft reline. I have the patient wear it overnight, and then 3 months later, I'll do a hard reline. Hey guys, I'm just going to ask you real quick, do you guys like it better when it's not split screen? Type like this if this is better. So let me know, split screen or single screen. All right, I just want to know what you guys prefer. All right, so this is the next one. Post-implant placement. Yeah, I'm going to switch you. Not sure what you mean. I see. If you remove the tori after implant placement, right? For sure, it's better to remove it before. But if you already have your implants placed and tori removal, for sure it's better before. Everything before implant placement. But I'm just showing how to fix some of these things that have already happened. So the reason that I'm sharing this is because I get called into a few different offices, and usually I get called in once the patient's already got a complaint, and the doc wants someone else to kind of fix what's going on. And so this is one of those situations. So post implant placement. All right, so Examples of complications: flared angulation. I mean, you guys know what I'm talking about here, right? Because in the maxilla, the bone is going one way. Right? I don't have a maxillary model on me. Let's see. In the maxilla, the bone is going kind of like this way, right? That's the fashion in which it resorbs, and then but you want your implants to be parallel, right? Your implants are like, you want your implants like this, but the bone is actually like that. So if you tell your surgeon friend to place the implants where the bone is, they're going to place them flared out. And so what do you do in those situations? What do you guys do in those situations anyway? I'd love to hear from you guys. So let's look at, so you can screenshot this if you want, but I'm going to show you in just a second. So there's two things that you can do. There's two things that you can do. One is you can use a angled locator, right? There's several places that sell angled locators. Blue Sky Bio sells it. DI sells it. There's a few different places that sell angled locators. Zest Anchors also makes an attachment, so a plastic nylon attachment that they call extended range. So you can, it's actually one of those little plastic attachments. It just doesn't have the little dimple in the middle of it that provides extra retention. So they're not going to be as retentive, but it lets you work with an implant that's kind of flared out. And so I've used that quite a bit. So this is another one, angled facially. This is pretty gnarly because it's really hard to deal with. This is a patient that I saw actually. Do I ever do conus abutments? I actually don't, but I can't say anything bad about them because I've never used them. So if anyone else here has used them, I'd love to hear from you. I'm going to flip this around again. So this is a patient that I saw at an office. They had their implants placed flared out like that, like crazy. So what I did was I flapped this entire thing and I alveoled the heck out of this. This bone actually was like really, really prominent facially. So I brought it back and I alveoled the crap out of it. I actually reduced some of the gingival tissue in that area. So this is, you see it 2 weeks after. This is just a 2 week after. So now I can actually change this out for an angled one, and I'm going to try to get a really short angled one. The problem with the angled ones is right where it makes the angle, right? So this part right here, like that, I don't know if I'm explaining it right, but the angle, that's the part that's the most prominent. So it's going to be, the part that's angled is going to be sticking out facially. So I'll keep you guys updated on that case. This case was, this picture was sent to me by Igor. Hey, Igor, I don't know how to pronounce your last name, man. Your Instagram handle is IggyDDS. This one was handled like a super pro. So I'm really happy with, I think this is really, really cool how it turned out. So you can see these implants. You might not be able to appreciate how facially angled these implants are, but you can see them right here. Impression copings are just coming right at you. Oh my gosh, that's just nuts. I'd be really proud of this case if I was you, Igor. Just being able to work with this is really impressive. The way that Igor solved it was, just to clarify, Igor didn't place those implants, but he worked with them. So he had a lab make some custom locators. So you see the screw channels right here and the locators up there. So they were able to get a good result afterwards. So let's see. These are the angled locators from DI I was telling you about. You see what I'm saying? So let me just, let me use this little. All right. So this is the angled locator. What I was trying to tell you earlier was this corner is the most prominent. This corner where it corrects the angle, that's the most prominent. So you can imagine if you have a facially placed implant, the corner is going to be right on the facial. So that's going to be, you need a little bit more space to correct that. Customized ball abutments. Well, that's awesome. I would love to see some pictures of that actually. So sorry, let me just repeat that. So Guarov says that he has solved a similar case with customized ball abutments. So that's also a very awesome way to fix this. So hey, what's up, Corey? Thanks for joining, man. right now we're talking about insufficient room. Those of you who are just joining now, you can kind of like rewatch this. I'll make it available later. But insufficient room, look at that. That is nuts. That's gnarly. The patient's just biting down, and the upper locator touches the bottom locator. This is a case that I'm working on, trying to fix it. And so for these types of cases, there's a couple of things that you can do. So one, you can flap alveo and make the gums thinner and switch them out for a shorter locator. Two, you can increase the vertical dimension. So I actually like to combine those two things, because once they look like this, you're totally screwed, man. That's crazy. Sorry, don't mean to freak you out if you have a case like that. But yeah, it's really, really hard to solve. So yeah, I would shorten that. I would increase the vertical. And third, my last option is just don't use one of those implants. If the patient was expecting that fourth implant, just go ahead and place another implant a little bit further forward, but do the proper alveo, and maybe just put one of those implants to sleep. All right, we're getting to the end here, guys. So if you want, you can screenshot that, but that's the solution I just talked about right now. You got to create space. So someone told me, who told me that tissue is the issue, but space makes the case. I don't remember, but that's really, really solid advice. So you got to cut down you got to do the proper alveo if your patient does not have very much room to place implants and dentures. So if they don't have the right amount of room, you got to do some alveo. One easy way that you can tell if they have room or not, look at their denture and get a little caliper and measure it. And if it's like 7 millimeters, if the thickness is 7 millimeters, you're going to be solid. If it's less than that, then I would do a little bit of alveo before you place your implants. All right, so let's see. So this is just me kind of measuring before, like how much alveoloplasty I need to do. I just use a little perio probe. It's a really easy way to do it. This part right here is a little bit tough though. You do want to be very careful. So I just use a little periosteal elevator. I reflect that back. This is like maybe like a little Woodson or periosteal. I just push that back, and then I slice that little peak off at the end. Which burrs do you use for your alveoloplasty procedures? So I bought the Pico spur block from salvin.com. I don't remember how much I paid for it. It might have been like $200 or $300, but it comes with a variety of different burrs. It comes with a big old round burr, and I use that for smoothing off bone or doing alveoloplasty if I'm only reducing like 3 millimeters or something. It comes with a straight burr that looks like a 557 burr. And so I use that if I'm going to alveoloplasty more. So if I'm alveoloplasty more than like 3 millimeters, I use this burr because I just cut the bone and then break it off instead of trying to like just smooth it off, because as you're smoothing, bones like flying in your face and like getting all over the place. It's nasty. So I only use that big old round burr for like small amounts of alveoloplasty. The Salvin kit also comes with a few other things like a small round burr and I forgot what else, but you guys can check it on their website if you want. What are you measuring on the denture so somebody's asking, what are you measuring on the denture with the caliper to assess for interocclusal space? So I might have a picture of it. Let me see. Okay, here we go. So I'm measuring that space right there. But all right, so what I'm going to answer you, Dr. Modi says, why not go for a diagnostic jaw relation, assessing the VD, then proceed with the treatment? All right, so perfect. You hit it right on. So in a perfect world, everybody is taking upper and lower alginates, mounting their case, studying their case, and then doing a treatment plan presentation to their patients. Is everybody doing that? No. If you got a high-end practice, or you really try to do good quality work, then yeah, work up your patience. I'm just kind of talking about troubleshooting, or a lot of offices don't do this kind of stuff, right? And so it might not be realistic to do all these analytics that you're talking about, but that would be the very best way to do it. And that's the way that we learned it in PROS residency. That's the way both of us learned it. So thank you for that suggestion. It makes a lot of sense. What you can do is use a caliper and measure their denture. But this diagram right here says measure from here to here. But I think that the relevant space is here to here, right? If you don't have I mean, you can have a long tooth, but if your implant is placed over here and you only have like one millimeter of acrylic, you're gonna pop that off. It's gonna break for sure. So I don't like this diagram. I'm gonna rework and make my own diagram. But you're using the caliper to measure the, I think from here to here. That's the most important right here. This could be whatever you want it to be, honestly. All right, so, oops. So I'm just gonna go back to where we were. This is one of those cases. You guys seen this case already? I placed those 4 implants and I restart it. I'm not gonna show you the video because it's on my Instagram profile. You guys can check it out if you want, but super proud of this case. I just delivered all on 4 for her, and you can appreciate how tiny her mandible is. Anyway, it looks like actually, oh, those are the 4 implants placed. That's it. That's it, guys. I'm not going to keep you here all day. You guys are probably on lunch break or something, but hope you guys enjoyed it. I enjoyed talking to you guys, and I'd love to hear your feedback. I have been a little bit lagging with my DMs. I'm really thinking deep about how I can restructure my office and restructure my work life so that I can bring you more content, so that I can help you more and document my cases more. And so I promise I'll be more responsive. For right now though, I think I've almost responded to everybody now, but anyway, a lot more coming. He said it's 1:45 a.m. What are you doing awake, man? 1:45 a.m. in India. How much leeway do you have on the alveoloplasty? Hey, thanks for the feedback. You're very welcome. You guys, I mean, your time's valuable too. And I want to try to deliver as much information as I can in a very short period of time, so you don't have to spend all day on here. But how much leeway do you have on the alveoloplasty? Okay, honestly, you have leeway, right? In dental school, I learned overdentures need a space of 12 millimeters of restorative space, 12 to 14 millimeters. In real practice, you can get away with less, but you don't want to be troubleshooting these things later, and you don't want to have complications, even though you might be able to get away with it. So like Dr. Modi actually said, the very, very, very best thing to do is take impressions, mount it on an articulator. You guys remember one of those, right? Mount it, and then see how much space you got, and use that for your diagnostics. All right, guys, I'm going to let you go, and you'll be hearing a lot more from me just right now. Remember, it's just a little bit of downtime. We've been really thorough. Actually, we've been really thorough about Olivia's consultations and whatnot, and now I'm just kind of like laying the groundwork for providing you with as much content as I can. One of those things is actually an all-on-4 online course, so I'm super stoked about that. I'll be giving you guys more info on it. But catch you guys later. Thanks for tuning in from India, guys. I love that. That's freaking amazing. All right, I'll catch you guys another time, okay? See ya.